video is about the topic clinical methods. After that, we will know about gastrointestinal system, hepatobiliary system, cardiovascular system, respiratory system, hematology, renal system, central nervous system, infection, endocrinal system, nutrition, critical care, emergencies in dental practice, anaphylaxis, and drug allergy. Each one by one. In this topic, clinical methods, we will know about the art of history taking, physical examination, scheme of general examination, and then about various systemic examinations. So, talking about the history, history is the physician's abstraction of certain facts and developed in the course of patient's interview and arranged in a manner that facilitates diagnosis. Proper history is important for making a correct diagnosis. This is the standard format used for history taking, in which we firstly ask the patient about their name, age, sex, marital status, occupation, and address. These patients' details are of very important for medico-legal as well as communication purposes. Then we ask about the main problem or chief complaint for which the patient has come to the doctor. These problems are listed in a chronological order of their appearance. Generally, the patient is allowed to tell by himself. Then, we take the history of present illness, in which leading questions are asked about the symptoms. Like if patient is complaining of pain, details should be recorded about site, severity, character, radiation, duration and timing, relieving and aggravating factors. After that, history of present illness, we take the history of past illnesses. A detailed account is noted about the illness which occurred in the past. Then we take treatment history, in which the details of medication taken are noted, and history of any adverse effects of the drug is also noted. Then we take personal history of the patient, which includes dietary history, appetite, work pattern, bowel and bladder habits, and any addiction patient have. Then we take family history. In this, any history of genetic disorders in the family is inquired about, and any history of similar illness in the other family members and cause of death of immediate relatives should be recorded. If our patient is a female, then we asked about menstruation, regularity of cycle, duration of cycle, and amount of bleeding are noted. After taking detailed history of the patient, we move ahead for our physical examination, in which we start with general physical examination. General physical examination usually start at the very point patient enters your clinic. We look for mental and emotional status of the patient, their facial expression, their walking pattern. After that, we look for the build of the body. The physique of the patient can be short, tall, obese, muscular, thin, or asthenic. Then vitals like temperature, pulse, blood pressure are noted. The temperature is measured with a thermometer and its normal ranges from 37.5 2 degrees Celsius to 37.7 degrees Celsius. In pulse, we examine mainly for the things like rate, rhythm, volume, character, radiofemoral delay, and synchronicity. Then, blood pressure is measured with the help of sphygmomanometer. Normal range for blood pressure is, for systolic blood pressure it is 130 and diastolic blood pressure 90 mmHg. After that we measure jugular venous pulse. It provides an estimate of central venous pressure and hence it denotes volume status and cardiac function of patient. After jugular venous pulse, we look for respiration. Normal rate of respiration is 12 to 16 per minute in adults. Any deviation is also noted. Then, the presence of pallor depends on the thickness and quality of the skin, amount of blood in capillaries, and quality of the blood in the capillaries. The evidence of pallor is looked at palpebral conjunctiva and mucous membrane of the mouth. Other sites are nail bed and palmar creases. After pallor, we check for jaundice. It is a yellowish discoloration of skin and oral mucous membrane due to deposition of bilirubin. Normal total serum bilirubin level is 0.3 to 1 mm per deciliter. Then we look for clubbing, which is the enlargement of the distal portion of the fingers and toes due to proliferation of connective tissues. We have made a detailed video on clubbing on this channel. You can find it out and look for it. Same for cyanosis, which is a bluish discoloration of skin and mucous membrane caused by increased quantity of reduced hemoglobin in superficial blood vessels. We have made a detailed video on it. Edema. Edema is the presence of excess of fluid in interstitial spaces causing swellings of the tissue. Then we examine for lymph nodes, size, number, texture, tenderness, mobility, and any sign of inflammation over the nodes. Then we look for nails and do examination of hands. After that, halitosis is seen. Halitosis is an unpleasant odor or smell emerging from the mouth or nostril that is detected by the patient or others. It is also referred to as bad breath. Now, when we have know about physical examination, let's move ahead to the scheme of general examination. This is a detailed list of the things we look during general examination. So we start with general physical examination, which you have learned just now. We look for general appearance, mental status, build, height and weight, and measure BMI of the patient. Then decubitus, which is the pressure source in bedridden patients. Then we look for the vitals of the patient, which includes pulse, innate rate and rhythm, character and volume, symmetry. After that, blood pressure, temperature, and respiration. all are measured. Then we move ahead for head to toe examination. So we start with eye and note down exothalamus, ptosis, eye movement. Conjunctiva is look for pallor and icterus. Pupil size, reaction to light and accommodation is noted. In face, we note for symmetry, puffiness, cyanosis, and also check for parotid glands. We will study about examination of parotid glands later. In oral cavity, we look for odor, lips for denture and other abnormalities. Gums, in gums we see for swelling, bleeding, inflammation, ulcers. In tongue, we look color, appearance, ulcers. And in buccal mucosa, we look for color and ulcers. Then pharynx is checked for tonsils, oropharynx. In neck, we see JVP, which we just read, then thyroid, lymph nodes, cervical lymph nodes. In upper limbs, we check nails, clubbing, quilonchia, pallor, cyanosis, pulse, blood pressure, lymph nodes. In lower limbs, we see edema of feet and ankles. So let's revise. In clinical methods, we studied about the history, physical examination, scheme of general examination, and systemic examinations. History is noted in detail, in which we start with patient detail, then move ahead and note down presenting complaints, history of present illness, history of past illness, treatment history, personal history, family history, menstrual history. After that, we do physical examination of the patient, starting with general physical examination, build of the body, temperature, pulse, blood pressure, jugular venous pulse, respiration, pallor, jaundice, clubbing, cyanosis, edema, lymph nodes, nails, examination of hand, and halitosis is noted. Now we studied about scheme of general examination, in which we see general appearance, mental state, build, height and weight, decubitals, vitals of the patient are noted. Then we do head to toe examination, in which eyes, face, oral cavity, pharynx, neck, upper limbs and lower limbs are examined. We have systemic examination of gastrointestinal system, cardiovascular system and respiratory system. Firstly, gastrointestinal system. So, the symptoms associated are abdominal pain, nausea, vomiting, heartburn, altered bowel habit, abdominal distension, bleeding, dysphagia, odynophagia, and loss of appetite. Dysphagia is difficulty in swallowing, which may occur due to problem in oropharynx or in esophagus, while odynophagia is a painful swallowing that may limit oral intake. Abdomen examination should be performed in a systematic manner, and this includes inspection, palpation, percussion, and auscultation. Procedure should be clearly explained to the patient. After that, we start with inspection. During inspection, patient should be supine and abdomen should be adequately exposed. The inspection should be performed under proper lighting conditions. In inspection, we note down the shape of the abdomen, umbilicus, movement of abdominal wall, and prominent veins present over abdomen and skin. Shape of the abdomen may be distended or shrunken. Umbilicus may be everted or horizontal as in ascites. Movement of the abdominal wall may be absent. Visible pulsations can be seen or there can be visible peristalsis. Skin of the abdomen is shiny or smooth in marked distension. Purple striae can be seen in Cushing syndrome. Pink or white linear marks produced by cross stretching of abdomen as in ascites and pregnancy. After inspection, we do palpation, which begins anticlockwise from left iliac fossa. During palpation, we see for tender areas, organomegaly, and fluid thrill. Fluid thrill detects the presence of free fluid in the abdomen. The normal note of abdomen percussion is tympanic. Percussion is useful in confirming the enlargement of liver and spleen and detecting fluid in the peritoneal cavity. Shifting dullness is a sign of moderate ascites and can be absent when the ascites is tense. The vowel sounds are heard in auscultation in iliac fossa. Now we will learn about cardiovascular system. The symptoms associated are dyspnea, chest pain, palpitation, edema, syncope, fatigue, cough, reduced urine output, and right upper abdomen discomfort. Firstly, in cardiac examination, we start with inspection and palpation. The lowermost and uppermost distinct cardiac pulsation is known as cardiac impulse or apex pulse. A thrill may be palpable in systolic phase or in diastolic phase. In apex suite, we look for character and location. In auscultation, we heard sound S1, S2, S3, S4, open snap, and murmurs. The first heard sound corresponds to the closure of mitral and tricuspid valve. It is the loud in MS and muffled in MR. The second heard sound corresponds to the closure of aortic and pulmonary valve. The presence of third heard sound in children may be physiological. The fourth heard sound occurred due to vigorous arterial contraction with a non-compliant ventricle. Opening snap is audible due to forceful opening of the mitral valve in diastolic phase preceding the murmur and heard in the case of non-calcific mitral stenosis. Murmurs are found because of turbulent flow within the heart and great vessels, and increased flow across the normal valve may also generate murmur. Murmur are generally defined by characters such as size, loudness, quality, timing, and radiation. Now, the important respiratory system symptoms are dyspnea, cough, sputum, hemoptysis, and chest pain. Dyspnea is defined as an abnormally uncomfortable awareness of the breathing. Hemoptysis is the coughing of blood in the sputum. In respiratory system examination, we study 4 headings: inspection, palpation, percussion, and auscultation. Percussion was absent in cardiovascular system. In inspection, we see shape and symmetry of the chest. The shape of the chest is normally bilateral, symmetric, and transverse in diameter is more than atrioposterior diameter. Tracheal shift can be assessed by looking for prominence of clavicular end of sternocleidomastoid muscle, which becomes more prominent on the side of the shift. This is known as trail sign. The movement of chest is normally equal on both sides. The movement is decreased on the side of disease. Then we see rate, rhythm, and depth of respiration. The normal respiratory rate is around 12 to 16 per minute. The tracheal and the apex beat are palpated to find out the shift of the mediastinum. The shift of the mediastinum to the side of disease occur in fibrosis and collapse. Mediastinum is pushed to the other side in the case of pleural effusion and pneumothorax. Then expansion of chest is measured and compared on both sides. Tactile vocal fremitus is detected with the flat of the hand placed on the chest of the ball. This occurs due to the transmission of sound wave produced in the larynx and proximal airways to the chest wall. Palpation also let us know about any tenderness present. Normally, the percussion note over the chest is resonant, but in the case of disease, it may be impaired or dull, stony dull, or a hyperresonant note is found. Normal liver dullness is masked in emphysema. In auscultation, we heard for normal breath sound. Normal breath sound heard over the chest wall are called vesicular. In case of disease, they may be bronchial breath sound and harsh vesicular with prolonged aspiration, as in case of COPD. Additional sound like wheezes, crackle, and pleural or are also found. Wheezes are high-pitched continuous musical sounds associated with narrowing of the airways. Crackles are bubbling or clicking, brief interrupted sound produced by the explosive opening of small airway due to sudden changes. About these gastrointestinal and hepatobiliary system diseases like stomatitis and oral ulcer, gingival hyperplasia, dysphagia, gastritis, and peptic ulcer. Stomatitis is the inflammation of oral mucosa. In this, disruption of mucosa may lead to ulcers. Here we will know about some common causes of oral ulcer. They can be infection due to viral, fungal, and bacterial agents. Viral agents like herpes, CMV, EBV, HIV, fungal agent like Candida, and bacterial infection like Vincent's infection and syphilis. In Vincent's infection, there are painful, slogging deep ulcers which primarily involves gums. Dermatological causes like pemphigus, pemphigoid, and lichen planus causes oral ulcers. Drugs used in the therapy of chemotherapy drugs, erythema multiforme, Steve-Johnson syndrome, systemic diseases like Behçet syndrome, SLE, systemic lupus erythematosus, and nutritional deficiency like vitamin deficiency of vitamin B and C and iron deficiency. Neoplasia like squamous cell carcinoma, leukemia, Kaposi sarcoma, and gastrointestinal diseases like Crohn's disease and celiac disease. Trauma due to dentures and corrosive and hot liquids can cause oral ulcers. Now we will know about gingival hyperplasia. It is the swelling or enlargement of gingiva. It can be generalized or localized. Causes for generalized gingival hyperplasia may be acquired or congenital. In acquired causes, we have acute myeloid leukemia, vitamin C deficiency, drugs like phenytoin, cyclosporin, calcium channel blockers like nifedipine, verapamil, diltiazem, amlodipine, and sodium valproate and tranexamic acid. Disease like Wegener's disease, which causes strawberry gums. Congenital causes are mucopolysaccharidosis, primary amyloidosis, hereditary gingival fibromatosis. Causes of localized gingival hyperplasia are also acquired and congenital. In acquired causes, we have lymphomas, multiple myeloma, squamous cell carcinoma, Kaposi sarcoma, pregnancy sarcoidosis, Wegener's disease, giant cell papules, which is due to primary hyperparathyroidism. In congenital causes, we have Fabry syndrome, tuberous sclerosis, Schwarzenberg angiomatosis. Dysphagia is difficulty in swallowing. It is divided into following types: oropharyngeal dysphagia and esophageal dysphagia. In oropharyngeal dysphagia, there is problem in transferring food from mouth to the esophagus, and in esophageal dysphagia, we have difficulty in swallowing down the food, the esophagus. Causes of oropharyngeal dysphagia may be mechanical or motor. Mechanical causes are oropharyngeal tumors, post-surgical radiation changes, Zenker's diverticulum, retropharyngeal abscess mass, thyroid disorders, Plummer-Wilson syndrome, and inflammatory lesions. Motor causes are brain injury, cerebral palsy, Parkinsonism, stroke, rabies, tetanus, cranial nerve palsy, Guillain-Barré syndrome, myasthenia gravis, botulinum toxin, myositis, and myopathies. Causes of esophageal dysphagia also may be mechanical or motor. In mechanical causes, we have esophageal cancer, peptic stricture, inflammatory esophagitis, Schach's ring, posterior mediastinal mass, aortic aneurysms. And in motor causes, we have atresia, scleroderma, diffuse esophageal spasm. Now comes our next disease, gastritis. Gastritis is a histological diagnosis characterized by inflammation of gastric mucosa. These are following types of gastritis: acute and chronic. Acute gastritis is usually erosive and hemorrhagic. It can also be due to infection. So we will first know about erosive and hemorrhagic type. Its main cause are drugs, alcohol, stress due to severe illness, congenital gastropathy due to portal hypertension. The treatment of acute gastritis consists of administration of sucralfate suspension and H2 receptor antagonists such as ranitidine. Uncommon type of gastritis may be granulomatous gastritis, eosinophilic gastritis, and lymphocytic gastritis. Now, peptic ulcer. They are present in the lower esophagus, stomach, and abdomen. Risk factors are Helicobacter pylori, NSAIDs, chronic obstructive lung disease, chronic kidney disease, coronary artery disease, obesity, diabetes, old age, and tobacco use. Treatment of peptic ulcer. In medical treatment, we use three things. Firstly, acid neutralizing or inhibitory drugs. Second, mucosal protective agents. Third, eradication of H. pylori. So, acid neutralizing or inhibitory drugs are our antacid, H2 receptor antagonist, proton pump inhibitor, and mucosal protective agents are sucralfate, bismuth, misoprostol. H. pylori eradication therapy is achieved with treatment in 85 to 90% cases. In this, we use standard triple drug therapy in which amoxicillin plus clarithromycin is given. Second therapy is bismuth containing quadruple therapy, and then non-bismuth containing quadruple therapy. This was, we will talk about hepatobiliary system. Topics are jaundice, acute viral hepatitis, cirrhosis of liver, ascites, and hepatomegaly. Our first topic is jaundice. It is yellow discoloration of skin and mucous membrane due to deposition of bilirubin in the tissues. The deposition of bilirubin in the tissues occur when the serum bilirubin level is raised. This condition is known as hyperbilirubinemia. The normal total serum bilirubin level is 0.3 to 1 milligram per deciliter. Sclera has a high affinity for bilirubin due to their rich elastin content. The other sites to be looked for the evidence of jaundice are mucosa of oral cavity, underneath the tongue and skin. Urine is dark colored in color due to excretion of conjugated bilirubin. In this photo, you can see we look for the evidence of jaundice in lower part of sclera. Jaundice is classified into two types, unconjugated and conjugated. The conjugated type is due to Dubin-Johnson syndrome and Rotter syndrome, hepatocellular diseases, or cholestatic jaundice, which is also known as obstructive jaundice, while the unconjugated type is due to overproduction of bilirubin or impaired hepatic metabolism. Now, acute viral hepatitis. Acute viral hepatitis is a systemic viral infection characterized by predominant involvement of liver. It is caused by one of the specific hepatitis virus like hepatitis A virus, hepatitis C virus, hepatitis C virus, hepatitis D virus, and hepatitis E virus. Other viruses are cytomegalovirus, Epstein-Barr virus, herpes simplex virus, and yellow fever virus. Hepatitis B is most important among them, and its symptoms are jaundice, fever, yellow dark urine, pale poop, nausea, vomiting, pain in the right side of the abdomen, joint pain, hives, headache, weakness, fatigue, and loss of appetite. Clinical features of acute hepatitis are divided under the various stages. Firstly, prodromal stage, in which non-specific systemic symptoms like anorexia, nausea, vomiting, headache, fatigue, malaise, myalgia, and arthralgia may occur. Second is icteric phase. Patient may notice dark urine and yellowish discoloration of eyes and skin. Clay-colored stool and pruritus suggest cholestasis. In recovery phase, there are improvement in general symptoms and diminution of jaundice. Signs of jaundice seen in sclera, which becomes yellow in color, and the skin may show stretch marks due to pruritus. Complication of jaundice may be hepatic or extrahepatic. Hepatic complications are acute fulminant hepatitis, relapsing hepatitis, cholestatic hepatitis, chronic hepatitis, cirrhosis, and hepatocellular carcinoma. Extrahepatic complications are aplastic anemia, Henoch-Schönlein purpura, glomerulonephritis, papular acrodermatitis, myelitis, neuropathy, arthritis, cryoglobulinemia. Treatment for hepatitis is to avoid much of physical activity, but bed rest is not recommended until it is a severe case. Drugs, especially hepatotoxic and those which are metabolized in liver, are restricted. Alcohol intake should be avoided. There is no specific therapy, and liver transplantation may be required in cases acute fulminant hepatic failure. Cirrhosis of liver. It is the end result of the hepatocellular injury characterized by the presence of extensive fibrosis, regenerative nodules, and loss of liver architecture. Two of the most common causes of cirrhosis are viral hepatitis, especially B, D, and C, and prolonged excessive use of alcohol. Other than that, non-alcoholic steatohepatitis, also known as NASH, is also a cause. Other causes are autoimmune hepatitis, drug-induced biliary cirrhosis, hemochromatosis, Wilson's disease, cardiac cirrhosis, alpha-1 antitrypsin deficiency, and cryptogenic cirrhosis. Clinical features of cirrhosis may show features due to hepatocellular dysfunctions, which are jaundice, ascites, hepatomegaly, spider nevi and Palmer erythema, gynecomastia, testicular atrophy, menstrual abnormalities, breast atrophy, bleeding tendency, hepatic encephalopathy. Features due to portal hypertension are ascites, splenomegaly, variceal bleeding, hepatic encephalopathy. Other clinical features are parotid and lacrimal gland enlargement, clubbing, opaque nails, Dupuytren contracture, and skin pigmentation. Lab features for finding of cirrhosis of liver are blood examinations, imaging, which is ultrasonography, is helpful in evaluation of liver size, texture, ascites, portal hypertension, and splenomegaly, endoscopy, and liver biopsy. Biopsy helps in assessment of the severity of cirrhotic changes. Management of cirrhosis includes general management, treatment of specific cause, management of complication, and liver transplantation. General management include diet, which should have adequate amount of protein and calories, vitamin supplement, and salt restriction. Medications which are hepatotoxic or metabolized in liver should not be given or should be given with caution. Treatment of specific cause like alcohol stoppage is mandatory in alcoholic cirrhosis, and specific therapy is needed in hemochromatosis and Wilson's disease. Next topic is ascites. Ascites is the accumulation of excess fluid in the peritoneal cavity. Normal fluid volume in peritoneal cavity is less than 20 ml. Causes for ascites in normal peritoneum may be cirrhosis with portal hypertension, congestive heart failure, hypoproteinemia, Budd-Chiari syndrome, pancreatitis, biliary ascites, chylous ascites, and Meg syndrome. Diseased peritoneum, tuberculous peritonitis, bacterial peritonitis, and malignancy. Investigations include ultrasonography and paracentesis. Ultrasonography of abdomen can detect presence of minimal amount of fluid and is helpful when clinical signs are not present. Abdominal paracentesis is performed as a routine investigation to determine the cause. It can be performed under ultrasound guidance. 50 to 100 ml of fluid is drained and examined for the color, total differential cell count, and malignant cells. Management of ascites is restriction of salt in the diet. Diuretics are given. Therapeutic paracentesis is needed in massive ascites. Next topic is hepatomegaly. The liver is normally not palpable. However, it is palpable in right upper abdomen when enlarged. The size of the liver is usually expressed in centimeter below the right costal margin. The consistency of liver should be noted as soft, firm, or hard. The surface may be smooth or nodular, and the edges may be sharp, regular, or irregular. Liver may be non-tender or tender to touch. Causes for hepatomegaly are vascular causes like congestive heart failure, hepatic vein thrombosis, inflammatory causes like hepatitis, cirrhosis, liver abscess, neoplasm like hepatoma, metastasis, lymphoma, leukemia, granulomatous causes like tuberculosis, sarcoidosis, and infiltrative causes like fatty liver, non-alcoholic steatohepatitis, amyloidosis, hemochromatosis, storage disorders, and biliary tract obstruction. In this video, we will learn about acute rheumatic fever, rheumatic valvular heart disease, infective endocarditis, hypertension, and ischemic heart disease. Our next video will be on the topic heart failure, acute pulmonary edema, congenital heart disease, and arrhythmia. Acute rheumatic fever is a multi-system disorder which follows pharyngeal streptococcal infection. Acute rheumatic fever affects children most commonly between the age of 5 to 15 years. Its diagnosis is based on updated Jones criteria. Presence of two or more major criteria or one major and at least two minor criteria plus evidence of previous streptococcal infection is required for the diagnosis of acute rheumatic fever. The major manifestations are carditis, polyarthritis, chorea, erythema marginatum, subcutaneous nodules. Minor manifestations are clinically fever, polyarthralgia. Lab investigations include elevated ESR, C-reactive protein. ECG shows prolonged PR interval. Supporting evidence of a preceding streptococcal infection within the last 45 days. Shows by elevated or rising anti-streptolizin O or other streptococcal antibody or throat culture or rapid antigen test for group A streptococcus. Treatment of acute rheumatic fever is based on eradication of streptococci. A 10 days course of erythromycin or oral penicillin is administered to all patients to eradicate streptococcal infection. Bed rest is required in patients with severe carditis. Salicylates like aspirin is given and steroids like prednisolone is given. Our next topic is rheumatic valvular heart disease. Most commonly affected valves are mitral valve, aortic valve. The disease may be stenotic or regurgitant. There are four types: mitral stenosis, mitral regurgitation, aortic stenosis, and aortic regurgitation. We will make a separate video about this topic. So for now, let's move ahead to infective endocarditis. It is a microbial infection of endothelium of the heart. Endocarditis is classified into acute and subacute types depending on manifestation and their clinical course. So, acute infective endocarditis has a rapid course, while subacute infective endocarditis have indolent course. Rapid valve destruction and abscess happens in acute type, while slow structural damage takes place in subacute type. Metastatic spread is common in acute type, and in subacute type it is less common. Clubbing, splenomegaly, petechial hemorrhages are not found in acute type, while they are found in subacute type. Acute type is fatal if not promptly treated, while subacute type has a prolonged course and less complicated by ruptured myocardic aneurysm or embolism. Causative organism for acute type are Staph aureus, while in case of subacute it is Streptococcus viridans. Clinical manifestation of infective endocarditis are general cardiac and extracardiac. General manifestations are fever, weight loss, night sweats, and weakness. Cardiac manifestations include new murmur, heart failure, and heart blocks. Extracardiac findings may be anemia, clubbing, splenomegaly, roth spots on fundus examination. Investigations done are blood culture echocardiography, and its diagnosis is based on Duke's criteria. For the treatment of infective endocarditis, the antibiotic should be administered parenterally to achieve high serum concentration since the vegetation is avascular. The therapy is generally of prolonged duration, and the selection of antibiotics should be based on culture report and minimum inhibitory concentration values. Our next topic is hypertension. Hypertension is defined as the level of blood pressure at which there is increased risk for target organ damage, and the benefit of the treatment overweights the cost and hazards. The diagnosis is based on the following categories. Office PP should be more than 140 mmHg systolic and more than 90 diastolic. Ambulatory blood pressure is used to evaluate blood pressure variable using oscillometric method over 24 hours period with large number of measurement along with the sleep measurement in patient own environment. It truly a reflection of BP. So 24-hour mean should be more than 130 for systolic and more than 80 for diastolic. Daytime or awake mean should be more than 135 mmHg, and for diastolic it should be more than 85. For nighttime mean it should be more than 120 for systolic and more than 70 for diastolic. Home blood pressure monitoring is done with validated electronic upper arm cuff device in the sitting position. It should be more than 135 for systolic BP and more than 85 for diastolic BP. As you can see here, that office PP is usually more than ambulatory and home blood pressure monitoring It is because of the white coat hypertension and is a result of anxiety upon visiting a physician or hospital. Effect of hypertension in target organs may be retinal damages, cardiac, CNS, renal, or on large vessels. Renal changes depend on the severity of the hypertension, while cardiac includes left ventricular hypertrophy, pulmonary edema, and high incidence of coronary artery disease, stroke, and transient ischemic attacks. Hypertension, encephalopathy are important effects on CNS. Effect on kidneys include polyproteinuria and renal failure. Investigation. There are some basic investigation to be done in all patients, which include urine analysis for protein, blood and glucose, fasting blood sugar, serum creatinine and blood urea nitrogen, serum sodium and potassium, serum lipid profile, electrocardiography. Investigation in a special group of patients which are at high risk include chest X-ray and echocardiography, renal ultrasonography and angiography, serum calcium and phosphate, thyroid stimulating hormone, urinary cortisol and catecholamine, plasma renin activity and aldosterone. Management includes some lifestyle modifications like relief of stress, salt restriction, weight reduction, regular exercise. Drug therapy include diuretics, ACE inhibitors and angiotensin receptor blockers, long-acting calcium channel antagonist and beta-adrenergic antagonist. Now comes ischemic heart disease. It is due to imbalance between oxygen supply and oxygen demand. It is defined as the lack of oxygen due to reduced perfusion. Ischemic heart disease has clinical manifestation such as angina pectoris, myocardial infarction, arrhythmias, heart failure, and sudden death.